Hi, I'm Dr. Barry Duncan, and today's webinar is about youth, families, and better outcomes now. Coming soon, you'll be able to have a composite graph of your child and adolescent clients with their parents or caregivers or other collateral raters. Stay tuned. Doing family work has always been near and dear to my heart. In fact, I had the great privilege of growing up as a therapist during the golden age of family therapy, when all these new, fresh ideas coming out that no longer located problems within the individuals, but rather within the context of families and other systems in which they were embedded. So many great ideas came out of that, and of course still persist now in the marital and family therapy field. First off, I want to call your attention to some other webinars that discuss the ORS, the SRS, and families. Good idea to check out the Nuances of the ORS and Nuances of the SRS videos. They cover all the groundwork of dealing with the ORS and the SRS. They serve as the prerequisite for today's webinar in many respects. So check those out first, and then go on to how you use the measures and PCOMS with families. Just a quick summary here of the clinical cutoff and getting a good score. The clinical cutoff for kids and adolescents is 28, and for caregivers is 28. Keep in mind that previously we had reported that 6 to 12-year-olds, the cutoff was 32. We have since reevaluated that data, looked at it, cleaned it up a bit better, took out the high scores, and the cutoff for 6 to 12-year-olds is now 28. And just want to refresh your memory about getting a good score. It's also relevant for kids, because if their presentation, if what they're talking about in their lives doesn't match their score, you need to deal with that in a very forthright way and explain to them that the CORS, the ORS work best when it represents their reasons for service and is an accurate description of their life. So all you have to do is, when they describe something that doesn't fit the way that they've scored the measure, just ask them about that and try to clarify. On one hand, you're saying on this CORS that things couldn't go much better. On the other hand, you're telling me that you're being bullied at school. Where might I see the being bullied at school on the way that you filled out the CORS? It's as simple as that, to make sure you get a good score that represents the client's experience and the reasons for service. One of the first things you have to deal with when facing a family is how you're going to utilize PCOMS. Who and how are you actually going to do it? So are you going to do it electronically? Are you going to do it with paper? Is the youth the identified client, or are you seeing the family as a whole with no particular identified client? What if you have two identified clients as well as the family? So how do you put all that together? First of all, you have to always consider feasibility and logistics. You definitely want to have at least the child or adolescent and a caregiver. Those are your main folks that you want to get scores from. You may have other people in the room, but you may really want to ensure you get those two ratings. Now, if you're using Better Outcomes Now, you want to ensure that you get the caregiver and the child's rating. If you have other SIBs in the room, you can also just give them the paper measures and let them fill them out so that everybody is included in the mix. Because frankly, if you have 5 people filling out Better Outcomes Now and you only have one iPad in the room, it could get logistically too slow to make any sense. The other thing you have to figure out is that if you have a typical scenario, which 90% of people who enter therapy with children, the child is the identified client. So in Better Outcomes Now, you open that as an individual client, and then you add a collateral rater to that. So you have 2 folks in the room, you pass the Better Outcomes Now iPad to them, they fill it out, and you're off to the races and can discuss it. If you have another caregiver in the room, you could do 2 caregivers or 2 collateral raters and still use Better Outcomes Now in an expeditious way. But as I said before, if you have several people in the room, you may want to let them do paper, but use the Better Outcomes Now for the folks you want to make sure go into the system. Now, if you have a scenario where a family as a whole comes in and don't really identify a particular client, you may want to enter them as a group so that they all take the ORS or CRS respectively, depending on whether the child or the parent, and that way they have ratings of their own. So then you will have all their ratings on the graph that you can toggle back and forth from to check out how each member of the family is doing. So let's take a look at that in Better Outcomes now. So I'm in as a provider, and I am now at the episode level. I'm going to add a client. So let's just say child 0830, and it's new. Yes, I am the provider, Barry Tess, and let's say that this is an individual, meaning that this is a child who's been identified as a client by some system, by parents, by doctors, by schools. We save that, and here we see that. We go into manage, and here's where we add collateral raters. So now we have to add the clients to this particular episode. So we can call the child the same as the episode identifier. Call this a child, and English, go through there. We're not doing it remotely, so we save. And now let's add the collateral rater. As you can see, this process doesn't take very long. So let's just say child collateral rater on this particular one. Against child English, they'll be giving the CRS because they'll be looking at the child through the CRS. They, of course, will be taking the SRS about their view of the session. We save that, and there we have both of those individuals in the system. If we wanted to enter them as a group, if it's a family of 4 and we wanted each of them to be able to take the measure for themselves without an identified client, then we would simply hit add, and here put in as a group, and then add the different members of the family that way, so you could toggle back and forth on the graph. You know, family work is not for the faint of heart. When you have more people in the room, things are more chaotic. A lot of times they're just more conflictual. People are distressed. To be a family therapist, you have to have high tolerance for chaos and distress and conflict. You know, it's not for everyone. Kids are going to be unruly at times, and adults are going to be unruly when they're dealing with their kids or with each other. So you have to have that. It's not as bad as wrestling alligators, but you kind of get the point. It's just more complicated when you have more than one person in the room. The graph is a snapshot of how therapy is progressing or not. It tells the whole story, and this visual kind of presentation of that is very useful. A lot of people are visually oriented. You know, when you see that flat line on the graph, it's very difficult, if not impossible, to ignore. I know when I started graphing scores a long time before it was done electronically, the flat line made a huge impact on me in my discussions with clients, as well as seeing the progress and being able to talk about it and get the client to take responsibility for it. Whereas it's useful with individuals, it's indispensable with couples and families, because you can graph the different viewpoints and have discussions with them in an open and transparent way. Here it is, of course, electronically as well. So, you know, with families, you can easily see their progress from different points of view. They can comment on other people's scores in relation to their own, and it really helps you know whether or not you need to do something different with them right from the beginning, right from the get-go, once you get their ORS score. Here it is electronically as well, provides the same kind of feedback. This visual feedback helps you have those discussions. You know, if you're seeing kids and parents, you got two scenarios, right? Sometimes they agree, and sometimes they don't. Most times, actually, they don't agree. But there are some places that they can agree. So let's look at first when they do agree. There's two ways that they can agree. They can agree about the level of distress, so if they have a similar total score, or they can agree about where the biggest area of concern is, or where their lowest domain is. For example, you can have a kid rate very high, but still one scale is lower than the rest. And if that matches up with where the parent's rating is lower than the rest, then you have an area of agreement that you can make comment on. So you give the ORS or the CORS, and you have the caregiver or parent and the kid rate it, and there you have it in front of you. You can say, gosh, it looks like you all are on the same page on where the problems are located. Who wants to start and tell me about what led to this lower rating for both of you? So you have that in common, or you could say, gosh, it looks like you guys are kind of on the same page about the level of distress right now, about what's going on. And they could be on the same page about both things, and I still then will add, it's a good sign when you're kind of in agreement about things. It means that you're on the same page or something to that effect. So you're kind of validating where they are, that they're seeing things in similar ways, and who wants to start and tell you kind of what's going on. If you've seen one of the videos that I like to use with Elizabeth and Sophie, they come in and they score within 1 decimal point of one another, 12.6 and 12.7. So I make comment on that, and they both mark not only have about the same level of distress that they're looking at, that the caregiver's view of the adolescent was very similar to the adolescent's view of herself. Not only were they similar about the level of distress, obviously just 1 decimal point difference, they were also in agreement about where the problems lied, and that is that they both rated the social or school scale lower than the others, which made very good sense because the 13-year-old hadn't been to school in nearly 2 years. So you just make comment on that, figure out a way to do it in a way that validates people's experience, and makes their similar scores a positive thing, because it is a positive thing. It probably reflects that this isn't the first time they've talked about these things, and they know one another's perspective about it, which is definitely a very good thing. Now, most times that's just plain not the case, right? That's just not the way it works out. You're going to have kids rating themselves higher than caregivers will rate the kid. But still, keep in mind, even though they have different ratings, one over the cutoff, one under the cutoff, they still could be reflecting where the area is that they are most distressed about. In other words, they still could have the same lowest scale on the ORS or CORS. Again, it puts everything out on the table for you to make comment on, and you can say, it looks like real different views about what's going on here. Who wants to start and tell me kind of what's going on? And you can lead that in and have the conversation. Oftentimes with adolescents or kids, when their rating is so different, after I've had that discussion with them, I might say, well, what do you think it's going to take to have mom's view of you more in line with your view of yourself? Because it seems like that may be what our task is here. You have very different views of how things are going. How can we get your mom to look at you the way that you look at yourself? So that kind of conversation. So we're dealing with the differences. We're making note that there are differences. We're asking people to explain the differences, but then we're trying to see what we can do about those differences in a very transparent way that puts it all out on the table so you can deal with it right away in the session. That's why I like the ORS and CORS with kids and families. It makes everything transparent. It brings it all out. There's no secrets, and I'm dealing with what we can do about it in therapy as soon as possible. So, in other words, when they don't agree, don't sweat it. I mean, actually, that's what you would expect between different generations, especially when the kid is IP'd as the problem, right? They're not going to see the problem in the same way, because keep in mind, the kids are mandated clients. They're drug into therapy. They don't usually say over a bowl of cereal in the morning, Mommy, Mommy, I want to go talk to a therapist today. They may at times, and most of the time, it's some system that brings them in. It's the parents, it's their doctor, it's the schools that bring them into service in one way or another. So they're little mandated clients. So we would expect them to not see or have the same level of distress as other people have about them. So think of them in that way. The great thing about kids and families is that we have the caregiver, the rating of the kid right there. We have that other viewpoint of the kid, so we can use those in tandem to have good therapeutic conversations about those things. Here in Better Outcomes Now, let's talk about a couple of different scenarios. So here, let's go to the graph page of this particular client and collateral rater, and you see that this client came in at a score of 28.3 on the ORS, and we can quickly toggle to the parent score. They came in at an 18, and on the initial look at that, they are very different scores. One is under the cutoff, one is over the cutoff, but let's look at their similarities in terms of the way that they rated the ORS. You can see on the parent clearly that the school scale is lower than the rest. On the child, you can also see that the school scale is lower than the rest. Of course, both of these individuals took the CORS, but the CORS is depicted here on the ORS on the graph page. But nevertheless, you can see that they both, although they have different levels of distress, depicted the problem in the same area, which would be a nice way to start off. You could say, looks like you have different kind of views about how distressed you are about this, but nevertheless, you are indicating the problem in the same area. Who wants to start and tell me how this scale got rated lower than the rest for both of you? And then go on from there. And of course, then you can talk about what's it going to take to move it 1 centimeter to the right. Now, another scenario we talked about, what if you have 2 identified clients? And so here's what your task is. So you're on the graph page, you dealt with this child and the collateral rater, and now let's go back to your rater page and click on this child and the same collateral rater. So here you see the child rated at 30.4. Pretty much everything high over the clinical cutoff, and here is the collateral rater rating things much lower, and really all scales pretty low, although the individual scale is a little bit lower than the rest. So that's all it takes is to toggle back to my raters, hit that graph button again, and you're back. So you can do 2 identified clients with a caregiver relatively easily, just clicking back and forth between the 2 individual clients that you happen to open. Here's a graph of an adolescent and a caregiver, and you can see that the adolescent is scored high and is doing pretty well overall, has enjoyed an increase, so you can talk about how those increases happened. And we toggle over to the parent, and they are seeing a slight increase as well, not seeing it going quite as well as the adolescent, but fertile ground to discuss. And here you have this graphic depiction of progress over time, which is indispensable to work when you're dealing with multiple people in the room, each of their views about the progress or what needs to happen next, and lets you know in a very quick glance how your therapy with these particular individuals are going. Let's talk about young kids for a second, 6 to 12-year-olds. When we say that the CORS is validated on 6 to 12-year-olds, that doesn't mean that all 6, 7, and 8-year-olds get it, right? It doesn't mean they understand it. Keep in mind, what is the cognitive task that the CORS demands? It demands that the kid can tie conceptually what happens in therapy to the way that things happen in between sessions. Right? That means the kid has to remember what you're talking about, the goals you've made, the problems you're discussing, and be able to reflect about how those things have gone since the last session. Not all 6, 7, and 8-year-olds can do that. By the time kids are 9, they pretty well can tie those things together. It's not a complex task. We're working on how your school's going. We're working on how you're getting along with your teachers. We're working on your grades. We're working how you're getting along with your stepmom. And then how has that gone since I've seen you last? And discussing that. That's not that complex of a task. However, kids are very here and now critters, as you know. The latency effect, or what's happened most recently, is going to hold sway over how they do their rating. So you got to do some coaching with folks. And some kids, no matter how much coaching you do, they're not going to make those very important connections to have a valid score on the CORS. But you know what? Don't sweat that. Don't worry. Be happy. Because that's why we have the caregivers. So if you know you don't have a valid score, if you know the kid isn't making the connection between what you're working on, a reason for service, and what's happening in their lives, don't sweat it. Just don't enter that data in the data system. It doesn't make any sense to enter invalid data. Still use the measures with the kid to involve them, to engage them, to make sure their viewpoint remains very important to the process, but you're not going to use their scores as being valid when you know that they're not, when you know they're not making that connection. That's why we always have the adult rating when we see kids. It just is invaluable to make sure we have that perspective and we can measure and monitor outcome according to the parent's view. But I'm still going to make every effort to try to get the kid's view in there. You know, a lot of times people think that you can't do PCOMS because it's too chaotic when you have several people in the room. There's a part to that that's absolutely true. It is more complicated, but family therapy is more complicated, period. So actually, I believe it brings some order to the chaos. It allows everybody to have a common purpose to do a joint family exercise together, to fill out the ORS, to graph the scores, to discuss the scores. It's a nice beginning point, just like the filling out the SRS, discussing the scores is a nice end point to the whole process. So it provides a structure and order to sometimes chaos that happens there. Earlier I mentioned that I had the great privilege of kind of coming to age as a therapist during the golden family therapy era. Just wanted to make a few very quick comments. First of all, I was introduced to family therapy by a great professor, Scott Fraser, who first led me to Jay Haley and the great article, The Art of Becoming a Failure as a Therapist, which made the point very emphatically that therapy had a purpose, and so did the therapist. That led me to the Mental Research Institute, which provided the original alternative to pathology, away from locating problems within individuals to what actually happens between people, what is the context of the problem rather than within individuals, that there essentially is no such thing as pathology, that the solution to the problem was the problem, which led me to solution-focused